Good afternoon. Welcome back. I'm glad to see so many of you after lunch. What we're going to talk about this session is also very important. It's about transition and the ethical principles associated with it. And you can think about transition with aging populations, that people transit from one state to another, from a state of health, varying degrees of ill health, and to end of life. And they may go upwards or downwards. And also in terms of healthcare systems. We have three speakers on this topic. And the first one is Dr. William Nelson, who's Associate Professor in Community and Family Medicine from the School of Medicine at Dartmouth, the Dartmouth Institute for Health Policy and Clinical Practice. And he will share with you his perspective on this topic. Thank you.
Well, thank you for that introduction. It's a real pleasure to be here, and I appreciate the opportunity to come and spend some time with you and cultivate a conversation with you. I thought I might begin by telling you a little bit about where I'm coming from, literally where I'm coming from. This is where I am based, which is in Hanover, New Hampshire, which is in the northeast part of the United States. Just to give you a sense of how cold it is, yesterday it was minus 18 degrees centigrade, which was, I did the conversion, 0.4 Fahrenheit. And one of our traditions, as you can see the snowy weather, and these are all real pictures, these are two medical students, and we have a tradition for our medical students to better understand our culture in snowy, cold New England, where we break the ice of a pond that's right next to the medical school, and then the students all jump into that pond in their bathing suit. It's part of the tradition. I'm on the admissions committee of the medical school, and we try not to tell them about that during the admissions process, that might be part of the introduction to our school. When I was chatting a little bit, I was saying I wasn't exactly sure what we meant by transitions here, because there's so many different transitions taking place between wellness or chronic illness and death, but also transitions along the continuum of care, from working with a primary care physician to being hospitalized. So there's all these different traditions or transitions going on, but there's also very personal transition. So a transition might be for how I'm relating to my parents and how that change might take place within the context of that transition. So what I want to do is just highlight a few things, and some of these are very, they connect very much and are very synergistic with what some of the other people have been saying. And I want to focus in on three primary areas. And of these three areas, I want to focus the most on that third bullet. So in these three areas, we certainly know about the growing population. What I thought I would show you, this is the global difference in ages. This is in, this is in China, and then this is in the US, but you can see the parallel patterns that are taking place. In the US, there is growing recognition of the needs of the geriatric or the elderly population. At our medical school, we now have required rotations in the clinical setting in geriatrics to better understand the needs of that population. But also, as I alluded to in a very personal note, I happen to live almost 2,800 miles from where my parents lived before they passed away. And so, like many other people in the US, and I'm sure in other countries, I had to struggle with, do I sort of leave my work? Do I leave my profession and go and live with them and try to help meet their needs? As it ended up, I would go out and fly out to the West Coast where they lived about every 4 to 6 weeks. And they were living in a retirement community. I think many people in the retirement community thought I did live there because I was there so often. But it created these sort of struggles within the context of a family dynamics. Yesterday when I was on a city tour here, the tour guide person, as we were wrapping up the tour, we were going by a cemetery. It was the Catholic cemetery. And my understanding was there was no place to put anyone. And then she said there's a policy, and this is what the guide said, there's a policy now that if anyone is buried in any cemetery in Hong Kong, you only can be there for 7 years. Then the body will be exhumed and then cremated. But then she went on to make the point that she thought that was morally inappropriate. At which point my wife elbowed me and she said, don't get into it with her. But she was arguing that it shouldn't even be 7 years, that no one should be put in a cemetery because land is so precious that we should. My point is that as we begin to recognize the needs, they are in many, many dimensions, not just in healthcare, but within family dynamics. The other point that I wanted to touch upon is many people would argue and suggest, certainly in our country, that there are limited resources. And by resources, I don't mean just dollar resources. I mean human healthcare professional resources. And that we have focused a great deal on specialized healthcare so that many medical schools now are beginning to ramp up their programs to produce more primary care physicians. But it's still a struggle because the average medical school student graduates with a massive debt because they have to pay for their education. And yet a specialty will receive much more salary, a much higher salary. So there's this struggle that students have about whether they want to be specialists, which is part of the system of care that creates that problem. But also part of that problem is the distribution. In the United States, 2/3 of the landmass is in rural settings. And that's about 27% of the population is in rural settings. And we have great shortages of healthcare in the rural setting compared to the urban setting where we probably have more than what we need, especially in the area of specialized care. So part of the whole resource issue in allocation is not just allocation of dollars, but allocation of our resources and where ought they to be. The third point that I want to highlight very quickly is variations in practice patterns. There's two basic categories of healthcare. One is the evidence-based or evidence-driven care. These are care and treatments that all with that need should receive. If I have a spiral femur break, for example, it's quite clear what should be done to deal with that, and that I should be a part of the decision-making process, but there's little doubt amongst the orthopedic physicians about what is the appropriate thing to do with that problem. But we have a great deal of healthcare problems and maladies that there is a somewhat uncertainty about what is the right thing to do. Because, as I note in the sub-bullet where I said, we really then have a problem with the underuse of effective care. So by that I mean, once we do gather evidence, it's been estimated that it takes anywhere from 8 to 20 years for that evidence-based care to really become part of the clinical practice. So we frequently have the underuse of something that's very effective. The greatest predictor of how a clinician will treat a patient is on how he or she was educated. And they may have been educated 20, 30, 40 years previously, and yet have not kept up with the evidence, even though evidence-based care should be the driver for what a patient receives. But we also have what's called supply-sensitive care. There was a movie that came out in the United States which had the great sort of line to it, if we build it, they will come. And that is, if you create an ICU in a hospital, you'll fill that beds. whether you need to or not. So it's called supply sensitive, so that service utilization based on not only building beds, but also creating a number of cardiologists or other types of specialists, they will cultivate then their practice and their numbers. And this can create what many people have called non-beneficial health care, or the overuse of non-beneficial care. And one of my colleagues and dear friends, Gil Welch, who just orchestrated an international conference on overdiagnosis, because frequently when someone is diagnosed with a problem, then it is assumed that we then have to treat that problem. Even though I'm sure almost all of us that have gray hair, we probably have, or that is of men, we have probably prostate disease. But does that mean that we have to be treated with seeding or surgery or for some other type of procedure? So many of us just adapt the symptoms and we live with the disease. So just because one is diagnosed doesn't necessarily mean one has to be treated. And that's why this other book, Overtreated, has become so popular and a theme within the United States. Are we overtreating people, especially during that continuum and along that continuum of care? Just to highlight this point, this is from what's called the Dartmouth Atlas. In the United States, we have extensive data on the utilization of care. And this is the map of the United States. And this is just the utilization of inpatient in the last 6 months of life. And you can see how it varies dramatically throughout the United States. The darker the colors mean the more inpatient stays. But what is interesting is even in the places where it's much lighter in color, the outcome isn't any different, which then leads to the argument of unwarranted variations because there's not a justification for the use of all those interventions. Hence, we have along that continuum of care, we have great variations in what interventions ought to be used and not used, especially leading to that concept of the overuse of non-effective or beneficial care. Now, this is not just a little bit of low-hanging fruit. So in this slide, you'll see in the United States, for example, that it's been suggested by multiple people that 30 to 40% of the healthcare dollar is wasted. 30 to 40% is wasted on non-effective, non-beneficial care. So it leads and goes back to something that I think it was Michael that said that when you decrease income, revenues coming in, someone's personal income is going to go down. Because if we're reducing the amount of coming into the money coming into the system, so whose income wants to be diminished? So that's why a lot of healthcare executives tend to say, well, let's do this because we'll be reimbursed by third-party payers anyway, so let's do that. So it's a major problem in looking at this in a systems way within the United States. And related to this is the importance and need for engagement with patients about what they want or don't want, and to give truthful information about the true benefits of procedures. And this is why we're building a lot more what we call decision tools that can be used. I think Robert noted about the importance of like end-of-life decision-making, about using some of these decision tools, and that's what you're seeing in some of these slides, where each one of the physicians has a document. It's not just a document that you sign to say that you consent it. It's a document that gives specific values-based data on whether something is beneficial or not beneficial, and how that might relate to then your own personal values. So let me close by just saying that we are growing to recognize the needs of the elderly, particularly the use of effective care and health promotion, which many of you and my predecessors have mentioned, we need to reduce non-beneficial interventions along that continuum of care, sorry about that typo, and reduce the unwarranted variations, and we need to be informing and engaging patients and participants in the decision-making regarding beneficial care. So what we're really talking about is something that was brought out in one of the very early panels, excuse me, is about how do we then integrate the alignment between ethics, quality, and value. Because I would argue that ethics is the basis for quality and value. It is why we're interested in quality. It's why we're interested in value. And that what we really need to do is create that alignment. And it takes many people. And I add to the litany that has been suggested by others that I would also look at organizational leaders. Do hospital executives and managers, do they really help monitor what is going on in clinical practices? Do they ensure that patients are informed using decision tools to help them gain insights into whether they want something or don't want something? So, thank you very much.
Thank you, Dr. Nelson. Thank you. So our next speaker is Dr. Elsie Hui, who's in charge of the New Territories East Community Geriatric Service and also Chief of Service of Shatin Hospital and Head of Division of Geriatrics in the Chinese University of Hong Kong.
Thank you, Professor Wu. Good afternoon, everyone. It's a great honor to speak to all of you here. And I want to share some of our local experience. I am by no means a medical ethicist. I'm just a geriatrician looking after lots of old people. So particularly for our friends from overseas, I'd like to orientate you to our healthcare system here. I think most of you would be familiar with the gold standards framework. It's one of the ways to identify people who have reached the end of life. There's a surprise question that healthcare workers are asked, would you be surprised if this patient died in the next few months? And there's other general indicators of decline. And to echo Dr. Nelson's talk, this phenomenon is observed all over the world. The last year of life, actually people will consume the most healthcare resources. And as he alluded, a lot of times we wonder whether it's really benefiting the patient in any way. So we have some local data which basically illustrates this. So for those who are institutionalized, that is a surrogate marker that they are generally very frail, and quite a lot of them have reached the end of life. So they're much more likely than other people to use hospital beds, to go to the ER department, and they get readmitted quite frequently, despite our best efforts to treat them. I think I'm going to skip the literature. I think there's a lot of worldwide literature that end-of-life care obviously is very important and can be achieved. This is a hallmark paper by a group from Harvard, and it's exactly the same picture here. What Susan Mitchell found was that for patients who were reaching the end of life, they frequently present to the doctor with 3 problems. The first is some kind of pneumonia, chest infection, or aspiration. Secondly, fever. And thirdly, eating problem, not eating properly and getting weak. So this is so common all over the world, repeating itself. And if you come to visit any of our acute hospitals, you would see lots of old people coming in with these problems. Locally, we've spoken to patients, and quite a lot of them express a wish of passing away in their own homes or in care homes that they're more familiar with. However, I'm going to elaborate in a subsequent slide why this is not possible at the moment. So locally, our government indeed does have an aging in place policy, and we have about 1 million elderly, comprising 13% of our population. Most of them do stay in the hospital, in the community. Only 7% are institutionalized. But as of last year, there were 70,000 nursing home residents. So quite a big number. And here is why we can't do end-of-life care in the nursing home, at least not widely. It's because our primary care system is not that well developed. So we don't have the one doctor, one citizen arrangement. Old people tend to rely heavily on hospital care. So if they get sick, they will come to the ER and get admitted. In response to this, our hospital authority did establish some outreach services. And I began my career as outreach doctor about 20 years ago. So they do not have a primary care physician. However, these at least they have an outreach doctor and nurse looking after these homes. And it is not normal practice for older people to die in nursing homes because all the deaths will be reportable to the coroner. And actually about 8,000 nursing home residents die in medical wards every year. So this is a very large number. Advanced directives and advanced care planning is still quite new to Hong Kong. And as I said, the majority of patients would die in hospital. And if they do not come to the hospital to die, they will be sent to the public mortuary. The case will be reported to the coroner. They may have to be subjected to autopsy. The police will come round to the home to investigate, and it's all terrible to the family. And if the patient died in a private, in their own residence, this might affect the price of the property because Chinese people are can be quite superstitious. So this is just to illustrate that old people will go through this revolving door phenomenon with repeated acute medical problems, and they will come to the ER, get admitted, and be subjected to various so-called non-beneficial and expensive interventions. And they may or may not die the first time round, so they go round this a few times, maybe 4, 5, 6 times in the last year of their lives, and finally they die. And we all agree this is not a very desirable arrangement. To follow up, I'm going to share some of our local experiences. In my district, we started out about in 2008 in a very small scale with no extra resources. But we tried to identify some patients who are eligible for end-of-life care in the nursing home, simply because it's easier to take care of patients who are institutionalized, because you have the staff of the nursing home to help you. We engaged the family to formulate some advanced care plans, and we put emphasis on symptom control. We try to support the elderly medically in the home for as long as possible, but if the condition really is getting worse, then we will coordinate direct admission to a designated place, hence bypassing the emergency room. So this is the advanced care planning. It's not a legal or formal document, but it is a discussion between the outreach doctor and the family, or maybe the patient if they are mentally sound. And it covers the commonly kind of treatment that is given that we feel is not so desirable for the patient in the hospital. And for the first time, the family and patient are provided options with emphasis on comfort and dignity, and hopefully to reduce unnecessary therapies. This diagram shows that from RCHE means a nursing home. So if the patient really needed to come in the hospital, previously they would go through the ER and come to the acute medical ward, but now they can be directly admitted to a convalescent hospital. This is a step-down facility which has more experience in looking after geriatric patients. And in some hospitals, the ER actually offers a farewell room, but also in our medical wards, we have this arrangement so that family can spend more time with a dying patient. So for the new pathway, just to illustrate, for example, if a patient develops fever with severe shortness of breath, we think they may have aspiration, rather than sending them to the ER, they can phone up the nurse, liaison nurse of the outreach team, who can then arrange a direct hospital admission. And as they already have advanced care plan established, we can focus on those items and respect the patient's wish. So if they survive, they'll go back to the nursing home until the next time. And if they do die, then hopefully they'll have a good death. So we piloted this on a larger scale in 2013 during the winter surge. And we found that actually up to half of the patients could be directly admitted just through logistical arrangements. And the compliance rate was quite excellent, and everyone was much happier. However, of course, there are limitations. This is not a 24-hour service, and sometimes the patient is far too ill. And sometimes we just don't have a bed even in our step-down facility to admit them. I'm pleased to report that actually the figure is now 75%. So again, this illustrates that rather than going to the ER and going to the acute medical ward and doing this cycle, now we're able to, through this program, we try to support the patient in the nursing home for as long as possible, and if they do need admission, then they're sent to a convalescent ward. And this paper was published in JAMDA as a model of care. And I just want to acknowledge the team. One of the doctors who actually take care of the patient is here today. And it is a multidisciplinary approach involving the family and also the staff in the elderly care facilities. And as I said, there has been no extra resources, and everybody was engaged because we truly believe this helped the patient. And there are other models that I want to acknowledge, that some NGOs in Hong Kong are very passionate about promoting good palliative care in residential care homes. So Tung Wah Group and Salvation Army, I believe there's representatives here today, so you might want to talk to them later. And they really do very in-depth end-of-life care, focusing on psychosocial support and so on. But the hospital model that I shared is the best we can do at the moment to at least smoothen the patient journey and to cut out the long waiting time and the anxiety and the frustration in the acute setting. The way forward, of course, we hope that we will have further development in Hong Kong, because although we believe these are good practices, they are still sporadic. There's a very urgent need for education and debate, and that's why we have this conference. And hopefully the government will be more receptive to what we say, and to train everybody involved, not only professionals, but also informal carers, and to adopt the practice that I described in the healthcare system. Because as I mentioned, there are 8,000 deaths a year in acute hospitals. And hopefully, with some new licensing arrangements, dying in nursing homes may be a reality in the near future. And the government is looking into amending the law regarding the coroner. So this is all I want to share, and I welcome any discussion after the talk. Thank you.
Yes, thank you very much, Dr. Hui, for highlighting the Hong Kong scene. Our next speaker is Professor Diana Lee, Professor of Nursing in the Nethersole School of Nursing from the Chinese University of Hong Kong.
Thank you, Professor Wu, and good afternoon, everybody. I hope you still remember the topic for our panel discussion today is on the ethics of care transition. So in the following presentation, I'm going to share with you about the what, why, and how of care transition. I'm sure you would all agree with me that care transition is a really very complex and challenging process, not only for the healthcare professionals, but also for the patients and the family carers. And if care transition is effective, it will help to achieve at least the following 3 goals. It will help to transfer care responsibility from one agency to another more effectively, and it will help us to plan for patients' continuing health and social care, and finally to promote the quality of care for both patients and carers. And therefore, effective care transition programs can actually help to significantly improve our patients' health and reduce readmissions. And who are the targets and who are the people that care transition programs are usually targeting at? These are usually high-risk, frail elderly persons with poor social and care support, such as those older people who are living alone or living with an aged spouse, those who are lack of a proper carer, or those who are unable to arrange the necessary community care services. And of course, it's not always true that care transitions are always effective. And in the literature, you can identify a number of outcomes or a number of projects which have been evaluated as very ineffective in terms of achieving the 3 goals that I've just mentioned earlier. And in summarizing the literature, it appears that ineffective care transition are usually a result of the following. First of all, it reflects probably a suboptimal assessment of the readiness for transition. Secondly, the planning for the transition could be incomprehensive and fragmented. Thirdly, there might be a breakdown in communication and information transfer between the 2 care agencies. And finally, after the care transition has been made, there might be inadequate post-transition care and follow-up. So ineffective care transition are usually a result of some of these. How about in Hong Kong? In Hong Kong, when you look into our documents and our research on this area, you cannot identify that there is a systemic policy-driven care transition practice. So in Hong Kong, there is not a systemic policy-driven care transition practice. And usually there is a lack of proactive and multidisciplinary approach to care planning and delivery. There are some of the examples of local care transition programs. For example, integrated discharge support program, in which a nurse will be visiting the patients about 24 hours after discharge, and this visit might probably be followed up by a physiotherapist or occupational therapist if needed. Another example of care transition schemes in Hong Kong is the nurse-coordinated transitional support through nursing visits or telephone consultation. And another example is the transitional residential care for elderly patients discharged from hospital. In this particular transition scheme, older people are being kind of like rehabilitated in a nursing home or OH home after discharge from hospital before returning back to home, so as to improve the functional ability of the older person. There are also a number of local studies which look into how effective are our care transition programs. And in terms of the work in our local literature, they have been able to identify a number of local barriers to effective care transition. And these include the following. First of all, almost all of the research in terms of evaluating our local care transition practices has indicated that all our programs are very disease-focused, to the extent that patients' preference, choice are seldom being considered. And when patients' choice and preference are seldom considered, it seems very likely that the carers' needs are very neglected. And so the third issue of carers' needs not being met is another issue in our local situation. And another problem is that a lot of the evaluation, which are particularly from the patients and the family's perspective, they have highlighted that healthcare professionals in Hong Kong, especially physicians, they have low awareness about patients' psychosocial needs. Poor communication between the 2 care units usually is an issue, and other issues such as service availability in terms of waiting time, patients' affordability, and other social factors such as transportation issues and the time gap between discharge and the service being made available are all other local barriers that could be identified in our local work. I just want to, from here, highlight a bit of another type of transition, which is most difficult for older people. This is the transition to residential care homes. In Hong Kong, I think Dr. Elsie Hui has just provided the information that about 7% of our older population live in residential care homes in Hong Kong, and probably this is ranked #1 in the world in terms of the percentage of older people staying in OH homes. And among all the types of transition to residential care home is a big event, a big life challenge for our older people because it evokes a lot of feelings of abandonment, stress and uncertainty, loss of a home, and the opportunities for contact with families and friends. And usually, transition to residential care home is very unplanned, and usually accompanied by deterioration of the older person's medical condition and functional abilities. And in most circumstances, especially in Hong Kong, elderly people have no choice and are not involved at all in the decision-making in going into residential care homes. And for Chinese older people, it is especially reflecting to them that going into an OH home reflects a sense of parental failure and a loss of respect from the family. And of course, they feel a lot of loss of faith, not only their own faith, but that of the whole family. So transition to residential care for older people, Chinese older people in particular, is an important issue. And in one local studies in Hong Kong, it has identified that older people living in residential care homes has a lot of issues concerning their quality of life. Existential distress is common among older people living in residential care homes. They are not able to find the meaning and purpose of life. They feel hopeless, helpless, and powerless. And they start to question the value of life. They're unable to achieve a sense of integrity, and they result in despair. And if you still remember Erickson's psychosocial stages of development, OH should be a stage when older people are able to reintegrate all the whole life to result in either integrity or despair in terms of their psychosocial development. And older people in residential care homes are kind of lacking for a sense of integrity, and they're having a sense of despair. So having gone through a bit of the information about what happens locally and about the difficulties in terms of transition to residential care homes, I think it is time we think about how we could improve our care transition practices. And it seems as if we need to make a shift from our present management of transition in terms of a disease-based model to a communicative and ethical approach that promotes quality of life for both our patients and our carers. And in doing so, I think we need to reorientate ourselves to a biographical, person-centered approach in our practice, and we need to develop a more collaborative partnership with our patients and their families and carers. And on top of this, of course, our system has to make a change in terms of our manpower, service availability for post-transition service, etc. And finally, and more importantly, we need to change our professional education. Communication and ethical issues about transition and patients' and carers' psychosocial needs, I think, should be included in our professional education for our health and social care professionals. Thank you.
Yes, thank you very much, Professor Lee. So a quick summary of this session, the topic of care transition. You've heard comments about family dynamics, education of students, distribution of resources, variation in practice patterns, the overdiagnosis issue, engagement of patients in patient-based decision-making. Also, an example from Hong Kong of really a bottom-up approach of frontline workers trying to make things better for patients and hopefully influencing policy, a sort of bottom-up approach. Perhaps later, Dr. Lin would talk about the Singapore approach, which is more top-down. And then finally, the issues about being lost in transition, and all the ethical issues that patients and family carers face. And I think that perhaps people who are managing, who are designing healthcare system should be more aware of these issues. So, and who are the people who care? I think people who care will make a difference. And perhaps I'd like to invite comments from the audience, because you probably have all experienced these issues, because we all have people that we care for. And so I welcome some comments about all the topics that have been raised by the panel members. I'd just like to make a comment about, one speaker talked about hospital utilization in the last months of life. And of course, we have a picture that all the services are used by very old people, very old and frail people, increasingly frail. But actually the statistics show that the people who use these services are the people in the last few years of life. And in fact, this is an inevitable consequence of aging. You live to 100 and you use more service in the last 3 years, say, so all your patients in the ward are going to be 97 and above, right? And if you look at the utilization based on age, there's no difference, very little difference between babies, people who are below 10, and midlife. You can imagine the situation. If you're dying of cancer and you're age 30, you're going to be in and out hospital for the past few years. So I think it's an important point to remember when we're discussing these issues.
Hi, I'm Dr. Philip Bear, and I want to correct, perhaps, or not correct, comment about dying at home and dying in elderly care home. I think there is a misperception, perhaps, that all deaths in elderly care homes are reportable deaths. It's actually more specific than that. It's got to be deaths in elderly care homes that are for profit, where the deaths would have to be reportable. So that's one thing. The other bigger problem we have is death at home, not in elderly care home, doesn't happen very frequently in Hong Kong for one very specific reasons. You can't get a registered medical practitioner to go to your home to certify the death and write the death cert. If you can, then the death does not have to be reportable, and there's no requirement for autopsies or transfer to public mortuaries, etc. But that's something we've not been able to overcome, in that very, very, very few private medical doctors are willing to attend your home to certify the death. But that may be something that, as a society, we might want to look at, and certainly try and prevent all these unnecessary admissions to hospital just to die. Thank you.
Are there representatives from the NGOs who run nursing homes, who run residential care homes, to share their experience? Perhaps Dr. Hui can make some comment about this coroner's business.
Yeah. Yes, the NGOs tell me, it's quite difficult, because you need to, a doctor need to have seen the patient within 14 days of the death. And upon the patient dying, ideally some doctor should come to the nursing home to write the death certificate. Again, this is quite difficult at the moment to arrange. But with some of the new homes coming in, the government has granted them a dual license. So they have what we call a CNA license and a nursing home license. And that allows them potentially to start doing some dying in place work. But I think for me, the process is not just about where they die, but when patients reach that final 6 to 12 months, you can see they're going in and out of hospital. And if you can give them a better service, I think that is, to me, is more important than where they die. If you see what I mean. Yeah.
I mean, it is, from the point of view of ethics, it's I think it's a travesty of our present legal system. I mean, it's not just for profit homes, it's subvented. Residential care homes, nursing homes are okay, but residential care home, because of the category, because of an outdated ordinance, says that if anybody dies there, you have to report to the police. The police always come, they have to, but it's a total waste of time. The point here is if you have the resident, the family, and the residential care home providers all working out a very happy system of dying in the residential care homes, they still cannot do it because they don't want the police to come. And surely you would think that this is a rather minor step that our society can correct. We can amend the ordinance that says under certain circumstances, like you have an outreach team and everybody agrees and so on, not to have to report to the police. It's a waste of police time, but they have to turn up at the home, and then you have to have the coroner wasting the coroner's time. I mean, it's these kind of examples where we hope to highlight the ethical aspects, because you're depriving everybody of their wish because of some outdated law, that there's a sort of inertia in amending. I would have thought it's fairly simple and non-controversial to amend this. So this is a peculiarity of Hong Kong. Singapore is probably different.
Well, first of all, it's hard to die at home in America also for other reasons, but I think it's not a unique phenomenon. But just to follow up on that, I'm curious, what is the resistance? Because I think one thing we look for in bioethics is not just to speak to each other in universities, but to engage with the political process and with decision makers. And you have people from the ministries of health here who I think would be interested. So I don't know the political process in Hong Kong by any means, but it would seem to me that that would be a very worthwhile goal, to try to address that, to try to engage with the people who are the decision makers. You have people from medical societies who I'm sure carry some weight to say, look, this is an outdated law that needs to change. So I don't know if it's because of issues of shame and stigma, in which case it's a cultural issue. I don't know if it's just the political process is just extremely hard to change on anything, but again, those are thoughts that I have just as reactions.
Yeah, I mean, I think this issue has been discussed successive decades in the Elderly Commission. I mean, I think Dr. Edward Leung pushed it, the Society of Hospice pushed it, HA kind of pushed it. I was in the Elderly Commission, I raised it, and it was never tabled. I sense that there's a reluctance to talk about it, to talk about death, so this is maybe a cultural thing. But when you talk about the objections, what's the problem? I don't know whether Alexander Lowe is here. She once told me you can't change government ordinance. You practically, it's a question of number. If you have vast numbers going to the streets to push it, then maybe you can achieve something. But a little group of people here and there talking about these vague things, they won't take any notice, which is and then there are objections like, supposing they dying at home. That's a problem, because if they die at home and a housing estate is so crowded and the lifts are so small, how can you get a coffin in there or the metal box, because it's strange things like that are being discussed.
Let me just add something, because I think it's a wonderful example of not only that particular issue, but many other issues that I think ethics can bring to the table. And that is this notion of, once we recognize we have these ethical dilemmas, and even though we may have worked through a specific one, but then step back and say, sort of, why did that dilemma occur in the first place? And what can we do to prevent it, or at least anticipate it down the line. So how do you bring the appropriate people to the table along that continuum of care or in the transition of care to bring them together to begin to think about how can we develop some consistent policy or practice, what I would call ethics practice guidelines, that can be then applied along that transition. So I guess I think it's really important not for us just to be reactive to ethical problems, but to then use that as a platform for then saying, what can we do to diminish that? Because we know the problems can happen again and again and again, even though the specific clinicians, patients may be different, but the basic problem's the same. So how do we then use ethical reasoning to promote the awareness of that problem, and then hopefully then to give us better insight as to how to address it later?
Yes, it's that's why I think it's also very important in the education of not just students, but all the people who are working to provide care, all the people who make decisions, to think about these issues in the light of ethical reasoning. But of course, we need to have capacity building in ethical reasoning. I'm not sure whether people explicitly analyze these issues in terms of, you know.
Oh, I think you're right. I mean, let's say a patient in care transition ends up in your hospital and then in the intensive care, and no one knows exactly what he or she would want. So then once you've sort of settled that problem and maybe the patient has died, then rather than making that the end, that should be the starting gun of a marathon, sort of like, why did that person come to my hospital, our hospital, without that advanced care planning document? What can we do in that system along that continuity of transition, so to bring the people together from whether that's a home program or a nursing home program, and say, how can we work together to cultivate our ultimate goal is, and that is to help understand what patients want or don't want.
And I think the education is not just in the health and social care professional, it's to the public. Because we currently have this rather strange situation where the ambulance people will always resuscitate anybody, in spite of the fact that there is an advance directive that was mentioned, stating specifically that the patient does not want resuscitation. The hospital authority had a big discussion with the ambulance people, and amazingly, they failed to convince them that if somebody has an advance directive that says do not resuscitate, to respect it. The ambulance association people understand that they are contravening a very basic ethical principle. Christine, would you like to comment? Dr. Christine Fang was head of the Hong Kong Council of Social Services.
Yes, I'm Christine. I'm a social worker. So I was trained to deal with the psychosocial needs of people, especially those facing aging, frailty, and dying. Hearing the whole discussion this morning, I think looking at the issue of end of life, which is we're all facing or will face, we need an overall policy, which clearly identify the goals of what's a good death. Like you have a choice of deciding your place of care and your place of death. Dying is a process beyond the individual. The whole family is involved. I think the issues that were raised, the problems we're facing is that I don't know if policy is an issue with an identified goal that cut across discipline so that we are not lost in the transition of care, so that we have an integrated medical and social interfaced care system and cut across medical legal barriers. These are the problems we are facing. And is it a policy that addresses the holistic needs of a person facing aging, frailty, and dying that needs to be addressing the whole issue of care in transition? I know that in UK you have an end-of-life care strategy, and also in Australia. Is it helping with, enforcing the ethics and the value and the principles of care? Do people fall in between the gaps? I don't know if there are experiences that we can share. A holistic end-of-life care policy that cut across disciplines, addresses medical and legal barriers, and medical social interfaces.
Would anybody want to comment on the UK experience?
So in the U.S., we have various policies at different levels. So there are state laws, there are national laws, there are city laws, there are hospital policies. And they help a lot, but not always. So in the United States, we encourage advance directives. However, we invariably, I'm on the ethics committee at Columbia, at the hospital ethics committee, and most of the cases we deal with are situations in which an elderly person signed an advance directive. They spoke to some of the family who were close, who said yes, and at the last minute, the long-lost son, usually a son, shows up in New York from California, usually California, has not been involved with the mother's care for years, and at the end says, "Don't you dare pull the plug on my mother."
And
I
it's
want
very
everything
guilty,
done.
Robert.
What's that?
He feels very guilty or grief.
Exactly right. He feels guilty, whatever the issue is, and so the hospital does not want a lawsuit, and so the hospital gives in to the son. So even though we have advance directive policies set up in the hospital, things come up that they're not always followed. However, usually they're followed. And I think the key thing is that even if advance directives don't have legal status here in Hong Kong, what's most important is that a discussion took place between the patient and all the families, so at least everyone's on the same page, even if the document doesn't have official legal status. So I think that one develops policies to be guidelines, and they help not all the time, but they can do a lot of work.
I think what...
Thank you. Thank you, Professor Wu. I have to identify myself. I'm the lucky person whom Professor Wu mentioned. Thank you for thinking of me. But actually, I didn't recall saying anything of the sort that Professor Wu said. I said, so it must be somebody else who said that. But I think if I said that, then I must be of unsound mind. So, but I think I hope to add a little bit of information about in the discussion, which is for amending the coroner's ordinance. I think we need to put it in context, because I think the list in the schedules, which include the residential care homes as being one of the places where a coroner autopsy has to be done, is to protect people who are institutionalized. So it includes not just the residential care homes, but also prisons and mental hospitals and so on. So I think it is a very worth topic to discuss about. But we probably need to think in terms of preparing the residential care homes for being taken off the list, what kind of safeguards we need in that setting. But I do not pretend to be an expert. I think just very close to me there are experts. Dr. Zhe, who I'm sure is somebody who have studied the issue for many years, and Dr. Leung, so I don't know whether I could pass the mic to them to say a little bit about it. Yeah,
Well,
thank you.
unfortunately, it's 3 o'clock, so I'm afraid we have to move on to the next session. But lots of, we can discuss among ourselves later. Thank you very much.
Thank you, Professor Wu, Dr. Nelson, Dr. Hui, and Professor Lee.